Hi friends, in this video we will learn about pleural effusion. The pleural space which lies between the parietal and the visceral pleura usually contains about 0.1 to 0.2 ml per kg of pleural fluid. Now the function of this pleural fluid is to act as a lubricant and allow the pleura to glide smoothly during inhalation and exhalation. When there is an increase in this fluid between the pleural layers, it is known as pleural effusion. This fluid is secreted by the parietal pleura and reabsorbed by visceral pleura. Now, before we understand the etiology of pleural effusion, let's look at the mechanism of formation of pleural effusion. Let us take a single blood vessel for representation and the diaphragm and the space between these two as the pleural space. The fluid within the vessels is in a dynamic motion with its surroundings, which are governed by mainly four forces, which is the plasma hydrostatic pressure tending to push the fluid out, plasma oncotic pressure, which tends to pull the fluid into the vessels, the tissue oncotic pressure, which is the pleural space oncotic pressure, which tends to pull the fluid out of the vessels, and the tissue hydrostatic pressure, which pushes the fluid back into the vessels. So the various mechanisms of pleural effusion can include increase in plasma hydrostatic pressure, decrease in plasma oncotic pressure, increase in the pleural space oncotic pressure, increased negative pressure in the pleural space which tends to suck the fluid out, increased capillary permeability, and simple transfer through the diaphragm. Further, the pleural space oncotic pressure can increase via protein leak, protein exudation, or defective lymphatic reabsorption, which tends to transport the protein which usually leaks out of the vessel. Now let us look at the etiology of pleural effusion. It can be divided into two types based on the type of fluid, which is a transudate and an exudate. The usual mechanism of transudate is increased hydrostatic pressure, decreased osmotic pressure within the vessels, or increased negative pressure in the surrounding tissue. The mechanism of exudate is increased capillary permeability. Now, a transudate and an exudate can be differentiated using Light's criteria. It consists of three features, and any single positive would indicate an exudate, whereas all three negative indicates a transudate. The first criteria is pleural is to serum protein ratio greater than 0.5, pleural is to serum LDH greater than 0.6, and pleural LDH greater than 2/3 the upper limit of normal serum LDH. Any value positive would indicate that the fluid is an exudate. Now let us look at the causes of transudates. Causes via the mechanism of increased hydrostatic pressure include left ventricular failure, constrictive pericarditis, pulmonary embolism, and superior vena cava syndrome. Transudate via decreased osmotic pressure within the vessels include hypoalbuminemia, as the majority of oncotic pressure is caused by albumin, liver failure, which causes decreased synthesis of albumin, nephrotic syndrome, and those via negative pressure in surrounding tissue include atelectasis. Other causes include hypothyroidism and Meigs syndrome. Causes of exudates include infection, which can either be a parapneumonic effusion, TB, empyema, viral or fungal pneumonia. Rheumatological causes, which include rheumatoid arthritis and connective tissue disorders. Malignancy, which can either be primary carcinoma of lung, pleural mesothelioma, leukemia, lymphoma, or METs. Other causes include pancreatitis, or it can even be drug-induced. Now, the presentation of pleural effusion includes shortness of breath due to increased work of breathing to expand the lung, cough, chest pain. This chest pain is due to the inflammation of parietal pleura. The character of this pain is sharp. It is exacerbated by coughing, sneezing, or deep inspiration, and relieved by shallow breathing or lying on the affected side. Coming to the diagnosis of pleural effusion. These signs may or may not be present in all the patients depending upon the severity and the cause. So vitals, respiratory rate may be increased. Temperature is usually increased in infections. However, it can also be normal. Edema may or may not be present depending upon the cause. Clubbing may be present in empyema or malignancies. Lymphadenopathy may be present in infection or malignancies, and cyanosis may or may not be present. Coming to the physical examination. On inspection, the trachea is usually central in location. However, it may be deviated to the opposite side in the later stages when the fluid is more than 1000 ml. Chest expansion will be decreased on the side of the effusion, and accessory muscles are used. On palpation, we confirm the inspectory findings. On percussion, we find stony dullness over the effusion, vocal fremitus is reduced, and shifting dullness may be present. On auscultation, we find decreased breath sounds over the effusion, decreased vocal resonance over the effusion. However, on the upper margin of the effusion, we may find bronchial breath sounds with agophony, whispering pectoriloquy. Now coming to lab diagnosis and imaging, we usually take this blood sample to rule out the causes of pleural effusion. So the tests we may need to do include routine complete blood count, LDH, rheumatoid factor, autoimmune profile, NT-proBNP. Now the value greater than 1500 picogram per ml is highly suggestive of congestive heart failure, ABG. Now coming to imaging, ultrasonography can appreciate small amounts of fluid in the pleural space. Coming to chest X-ray, the lateral chest X-ray can appreciate about 50 ml of fluid. However, the posterior-anterior view can only appreciate the pleural effusion when the fluid is greater than 200 ml. Aspiration of pleural fluid is done and the following characteristics are noted. Appearance, protein, LDH, glucose, pH, cytology for malignancy, culture, cell count, AFB and ADA. Now the normal values of pleural fluid is that the appearance is clear to straw colored, the glucose level is similar to plasma, LDH is less than 50% of plasma, and the pH value ranges from 7.6 to 7.64. Now let us look at the diagnostic criteria of the pleural fluid. Now if the appearance is bloody, our various differentials could include malignancy, TB, pulmonary embolism, or trauma. If the pleural fluid appears milky white, our differential could be chylothorax. In this, triglyceride level would be greater than 110 milligrams per dl. If the LDH value is greater than 100, the differentials include empyema, malignancy, rheumatoid arthritis, connective tissue disorders, and paragonymous Westermanni infection. For decreased glucose and decreased pH, our differentials include empyema, malignancy, TB, esophageal rupture, or SLE. Now coming to the management of pleural effusion. The main principle of management is to treat the underlying cause. Treating the underlying cause would also get rid of the pleural effusion. Second treatment option includes aspiration of the pleural fluid. Now, if we aspire the pleural fluid too fast, the BP may fall and re-expansion pulmonary edema is the complication. Therefore, the speed for aspiration includes 1000 to 2000 ml per day. Third management options include inserting a chest drain. Now, the indications for a chest drain includes empyema or parapneumonic effusions with purulent fluid and whose pH is less than 7.2, malignant effusions which are candidates for pleurodesis, and increased effusion in acutely unwell patients. Now, the next treatment option includes pleurodesis. This is usually done to prevent recurrence in cases of malignancies. Now, coming to the complications of pleural effusion. This could include respiratory failure, infection of the pleural fluid, or empyema. So, we've discussed about the pleural fluid, the mechanisms of formation of pleural effusion, its etiology, presentation, diagnosis, management, as well as the complications. I hope you enjoyed the lecture. If you liked it, please like, comment, share, and subscribe for more such videos. Thank you.